say. One, Rick and I are very excited to be here. I hope you guys learned something from this, but I always learn something from all these trainings, because you guys are out in the field, and you guys always teach us something that I would take to the next training. So I'm always learning from you, so I'm appreciative to be here. The other thing I wanted to talk quickly about is the app that Rick talked about, and we have some postcards in the back if you want some. But it's not just an app in the Google Play Store and the Apple Store. It's also a web-based questionnaire. So if you have veterans who don't want to do an app, they can do a web-based questionnaire. And they can email themselves, and they can also email you the results. And this is not to get us business. If you actually look at the end of it, we send to VSOs, and you guys are specifically listed as a VSO to go to. So this is just to help veterans and help you guys try and get like a starting point. So if you ever have any questions about that, please feel free to reach out to me. And the other thing I wanted to do quickly, because Rick forgot, is we always like to try and figure out how long you guys have all been in doing this. So who's been doing this for more than 20 years? Okay. Who's been doing this for 15 to 20 years? 10 to 15 years? 5 to 10? 1 to 5? Less than a year? Okay, so we got a big array of knowledge here. As Rick said earlier, I've been doing this for 13 years. I spent my first 9 years at the Board of Veterans Appeals, and now almost 4 years at NVLSP, and I do a wide range of stuff. If you do our webinars, you're probably going to hear my voice, because I do a lot of the webinars. And if you do our webinars, you'll learn that I like interactive training, how I best like to train. So this is going to be interactive. And if you ask the last group I trained, I will call you out if you're not participating. So I expect you guys to participate. So we're going to talk about common VA errors. And the first thing we're going to do is the top 5 reasons for an adequate exam. And then we're going to talk about lay evidence, effects of medication, and then mental conditions. So an adequate exam. So in certain situations, not all the time, but in certain situations, the VA has to provide exams, right? And sometimes it's when they meet the 4 elements that we call the McClendon elements. So the first element of that is that there needs to be some evidence of either a disability or persistent or recurrent symptoms. Then there needs to be evidence establishing that something happened in the service. The third, and this is the one that kind of gets you over that bar, is that there's just an indication that the symptoms may be associated. Just a very low indication that the current disability or the current symptoms may be associated with the military service. And the last, kind of common sense, right? The record isn't good enough to make a decision, so we need to get an exam. Now, once they give an exam, it has to be an adequate exam. And we know that they don't do adequate exams, right? Quite frequently. Last year, I did cases at the court, and I had about 50 cases, and they were all on one topic that we're actually going to talk about, on an adequate exam. So we see that they do these all wrong, but as an advocate, this is where you guys can really help out. The earlier you point out that an exam is inadequate, the more likely it is to get fixed, right? Because you keep beating them over the head. But you kind of need to get the statement and show them exactly why the exam is inadequate. So one of the things that I like to say, Rick was talking about that LSW program earlier, and I mentioned the VBA Remand Project. I helped start that. And I always tell my mentees that, you know, when you do your math homework when you were little, and you had to draw the blocks, so you knew 1 plus 1 equals 2, but you had to draw the little blocks to show it. That's how I treat the VA. I treat the VA like my math homework. I draw the little blocks. I connect the dots for them. I never want to leave anything out to the VA and think, well, they'll figure it out, because they're not. Part of that, you know, is production. They have production standards that are really high, so they move fast. So the clearer you can make things for them, the clearer, instead of saying, oh, it's inadequate exams, and you tell them why, the faster, hopefully, they'll pick up and fix it, right? So we say, make a quick little statement. I also hate boilerplate. There's so much of it in the VA world, right? And it's usually saying nothing. So just a couple sentences, quick, point out why it's wrong. That's good enough. So we have throughout this, I'll have like pages, little sections of boilerplate if you want them, so you can refer back to them for later. And the one thing, and Rick kind of talked about this earlier, we are giving you so much information today, and I do not expect you to grasp 99% of it. But if you get one thing out of every presentation, or when you go back later on and you think you're doing a case, you're like, oh wait, I vaguely remember that we talked about inadequate exams, and then you pull out the material, then I'll be happy, right? So I don't expect you to get all this today, but just know it so you can refer back to it. Okay, so the top 5 reasons. Number 1, I reviewed the veteran's claim file, taken the medical history from him, and performed a physical exam. It is my opinion that the veteran's respiratory condition is not caused by or a result of his military service. Is this adequate?
No.
You guys sure?
Yes.
You're correct. Now why? Why is it not adequate?
Doesn't explain why.
Okay. Doesn't explain, there's no rationale. And that is correct. There's an inadequate rationale. So the examiner did not provide an adequate supporting rationale for his or her medical opinion in this one. And this is what I like to say, you can't have mom says, right? Yeah. You always have that with kids, mom says no. There's no reasoning, just mom says. The VA can't do a mom says. They have to say why. They have to explain it. They need to be able to do it so that if you have another medical opinion, you can compare them. Now this is important also if you are able to go out and get a private opinion, that you have them give a rationale, right? So there's something to compare. So here's your boilerplate. So attack the adequacy of it, of a negative VA opinion, argue that they either have to obtain a new exam or opinion, say that it lacks a supporting rationale, there's a flaw in the rationale. Now, at NVLP, we are huge fans of going out and getting your own opinions if you can, either from their VA doctors or a private doctor. Sometimes, if you're lucky, you can get, like med schools will give low bono opinions and stuff like that. And so if you have a good opinion, a good private opinion, don't say that they have to go get a new exam. Just say, this one's not adequate because there's a flaw in the rationale, there's no supporting rationale, but here's my great private opinion that has all of it, and they should take that. Okay, so now we're on number 2. The veteran files an increased rating for the left knee. The VA examiner states, the veteran experiences severe flare-up of his knee every 1 to 2 months that lasts about 3 to 7 days. These flare-ups cause significant limitation of motion with functional impairment. You see this a lot, right? Is this adequate? Who says yes? See hands. Who says no? Who says they're not sure? Okay. A lot of people raise their hand. I'm going to give you a pass for this one. But you're correct. It's no. Why?
It can't be rated on a different flare-up.
We say it again?
It can't be rated specifically just on flare-up.
Explain it more.
Well, because it's supposed to be rated on an average, what they experience on an average day, not on their worst.
Okay. But this says this talks about how often there's flare-ups, right? So I guess you're right in the fact that you can't be rated on like the number of days flare-ups in the way, but you're onto it, but what else with it?
There's no range of motion mentioned.
Right, they didn't properly address functional loss. They don't say how bad it is. You can be rated, you know, if you are having so many flare-ups and it's just making your functional loss awful, you can be rated on that. So they have to say where the functional loss is. They have to talk about the effects of the pain or other impairments during the flare-up. A lot of times we see this, right? There's the Mitchell and DeLuca cases. The VA examiner will even reference Mitchell DeLuca in their opinions. And what this says in it is that they have to give it in terms of a degree of additional range of motion loss. So they have to talk about how much range of motion they lose because of these flare-ups. Does that make sense? Okay. So in the previous hypo, they acknowledged the flare-ups, but they didn't talk about estimate range of motion loss during the flare-up or explain why they couldn't give that opinion. So if they don't give it, then they need to say why they're not giving that opinion. They can't just totally ignore it. So they also have to address pain, weakness, disability, or incoordination. And they need to, if they don't discuss it, they need to say why not. If not, the exam is inadequate. Here's some boilerplate. So one of the things I always, when you have veterans, or even anyone, right, when they go to the doctor, they'll go in, even myself, go to the doctor, somehow you forget all your symptoms, right? You walk through that door and all of a sudden you're fine. I was at a doctor a couple weeks ago, my husband was with me, and the doctor asked me something, and I said, no, I don't have that. And later on, my husband goes, you complained about that every single day for the past week. Why did you tell the doctor no? And I was like, I don't know. I think in my head I was answering a different question. I was anticipating the question, right? So this is where it can be helpful to have your veterans write it out, talk about their flare-ups, and actually talk about their range of motion loss and how much they lose. So get that into the claims file, bring it to the exam so they feel prepared, they can hand it over to the examiner, and they can say, hey, actually, let me show you. So if they have it in front of them, and they compare it ahead of time, then it will be a better exam, right, and if it's in there. So when the VA examiner says they can't give an opinion, why not? The veteran gave you the information, right? So see if they talk about the functional impairment or states why they can't give the finding. Number 3. The veteran is service-connected for a right knee disability. The VA examiner is asked to opine on whether pain, weakness, fatigability, or incoordination significantly limited the veteran's functional ability through repeated use over a period of time with flare-ups. He responded that he was unable to say without mere speculation because it was not observed. We see this a lot, right? This comes after the Mitchell-DeLuca criteria. This is like the next part of the exam. We see this all the time. Like I said, last year I did like 50 cases at the court. They were basically all on this and the previous. They do this wrong all the time. Is that an adequate opinion?
No.
You guys sure?
Yeah.
Okay. Why? Mere speculation. Perfect. I don't need to be here. You guys got this. The failure to provide rationale as to why the speculative provide an opinion. They have to provide a rationale for the inability to provide a conclusory opinion. This goes to next opinions and to the severity opinion. You know, when they give a next opinion, they can't say mere speculation. They have to say why. So if they fail to provide an opinion, because doing so would require speculation, it must be clear that they have looked at everything in front of them, all the data, and looked at everything they can, and the examiner must explain the basis for such an opinion. They can't be a mom says, right? They have to say why they can't give an opinion in detail. Now, is this because there needs to be additional testing? Is it also because this examiner is not smart enough? Is this the first time that the examiner has seen it? We don't know. They don't tell us of why they can't give an opinion. It could be that they're not informed. So is there, is it due to the lack of medical expertise? Could we have additional testing? Is it just mere speculation opinion? Is this the limit of the knowledge of this one examiner, or the limit of the knowledge of the whole medical community? If they don't give any rationale of why, we don't know what's going on, right? They also don't need to directly observe the flare-up or examine the veteran after repeated use of time. We know they go into the exams, right? And they move their knee 3 times and that's it. They have to look at everything. They have to talk to the veteran. They have to look at that statement that we just talked about. And they to give an opinion. They don't need to actually observe it. They should be smart enough to take all the data and figure it out. So here's some more, So they have to look at the lay statement. So they have to ask the veteran about the frequency, the duration, the severity, the characteristics, the extent of the functional impairment. Our advocacy advice for this one is to fight it. Fight that they think that they have to see it over and over again. They don't. They have to get the information from the veteran. They need to look at the claim file and figure it out. They don't need to see it. Can they not give this opinion because they're not smart enough, because they don't have a lack of knowledge, or could a more qualified examiner give this opinion? They need to talk about this. So as we talked about earlier, help the veteran prepare a statement about the functional loss during flare-ups after repeated use. Talk about the frequency, the duration, the causes, use percentages, and other observable markers. I was ahead of myself before, wasn't I? So this talks about, talking to them about the bending over and asking the examiner to measure, say to them, how does that maybe demonstrate for you? I can see what you do now, but how bad is it with your flare-up? And then you can go in and show that to the examiner, and the examiner can actually measure it. Okay, what number are we on? 4. Are you sure? Yeah. Okay. You're right. The veteran served from 1975 to 2005. In a 1985 service treatment record, he reported his foot hurt during marching. He filed a claim in 2017 for a foot condition. The veteran provides statements from himself and family that he had foot pains in service. The May 2017 VA exam stated the current foot disability is less likely than not related to service. According to the claim file, the veteran did not complain of foot pain until he filed his claim for service connection. Is this adequate?
No.
You guys sure?
Yes.
Okay, you're correct. No, why?
Because veterans life statement is the evidence.
Okay, because there's evidence that it was during service he reported it. So this is based on an inaccurate factual premise. You see this sometimes, right?
Yeah.
Where the VA examiner will say something and you're like, where did they get that from? Pretty clear in the record. So if they give an opinion that is based on an inaccurate factual premise, there is no probative value to it. It's just throw it away. They should discount it entirely if you get one of those. So if you see an opinion like that, go through the service treatment records, right? And just look, is there anything in there that, he did complain?
Take a second and tell me what the word probative means and give me some, help me learn that. You can do that in 60 seconds.
So no probative value means that it's not going to be helpful, right? Or it means nothing. If there's no probative value, it's not giving anything to this case. We can't use it to grant a case. It means
it's not relevant.
It's not relevant. It's basically useless. So I'm going to check the definition in the dictionary.
So on that statement there, you said if it's inadequate, they got to throw it away. So you call them out on it, and they give the veteran another exam. That next decision then shouldn't even list that examination as evidence.
It should list it as evidence just because it happened and we don't want them to start missing things, but they shouldn't use it in denying the claim. Does that make sense? So if the examiner gets the facts wrong, argue that the exam is inadequate because it's based on an inaccurate factual premise. Okay, so what number are we on? The last one. We're still going after this. Okay, so number 5. The veteran filed an increased rating claim for diabetes, currently rated at 20%. In order to get to 40%, they require insulin, restricted diet, and regulation of activity. In March 2012, the veteran says, my treating physician informed me that my diabetes condition requires regulation of activity. The VA exam that same year, the VA examiner says, the veteran's diabetes requires insulin and restricted diet. However, the condition does not require him to regulate his activity. Do we see this a lot?
Yeah.
Do we think this is adequate?
No.
Yeah, you guys don't seem so convinced. Who says yes? Who says no? Who says not sure? Okay, let's do one more time because there's like a whole group that didn't stop to acknowledge it. Who says yes? Who says no? Who says not sure? Okay, so this one is no. Do we know why?
The examiner can't make a diagnosis of what the individual's medical condition should be. The examiner can't determine whether or not the veteran should restrict activities or not. A doctor has to make that determination.
Well, the examiner is a doctor.
I think that you...
Wait, hold on. I want to finish this one. The examiner is a doctor.
Not necessarily.
They're a medical professional. They can be a nurse practitioner who's also, while not an MD, does have medical training. But they are, an examiner is usually some sort of doctor.
Well, we're not giving an explanation as to why they said...
Right, no, hold on. Does that make sense?
That makes sense. I haven't found that most of the people that we see send to the medical professionals are doctors or are trained in that particular skill.
Well, they can be a general doctor. You can be a... That's
like,
right.
if the general practitioner got an MD or a DO after their name, I'd buy that. When I have an exam that's sent out to one of these outpatient, outsourced
Right, like LHI.
LHI or somebody, frequently all I have is a name that doesn't show that they have any specific medical training at all.
So, we're actually going to talk about that this afternoon, about if you are unsure of an examiner's qualifications. We are going to talk a case about that later this afternoon. However, those are mostly, they should all be some sort of medical professional. If it doesn't have it on there, you can question it and get it on the record, and that's what we're going to talk about later. Also, I would always do a Google search. You can always Google search the name and see if they come up as a doctor or not, but I would say for the most part, they should be all medical professionals. I haven't really seen where they're not some sort of medical professional. Now, yes, sometimes they're nurse practitioners, or sometimes they're clinical nurse and social worker for psych stuff, and we can argue into that. That's a whole other argument. But they usually are some sort of medical professional to give an opinion like that. So if you're not sure, and we will talk about this later, definitely get it in the record, because if you don't get it on the record, then you've lost the chance of, if we get the case to the court, we can't argue that. But I would always do a Google search or something like that as well. Okay, what were you saying?
I think that if I'm required to keep my insulin and control my diet, that is regulating my activity.
It's actually not. The regulations say regulation activities has to do with other things, and the criteria lays it out that those are different. So it's not.
Well, that's what I was going to say, that they did not medically explain why that individual doesn't have to regulate their activities.
Okay, so there's no explanation. What else do we think with this one? Yes?
I think in this specific case, the veterans lay evidence, VA's would probably argue that it's subjective because it's not in the treatment records.
Okay. In this one, it's failure to address the lay statement. So they need to talk about the lay statement. While we all know the VA likes to reject lay statements all the time, they at least have to discuss them, right? There is a big push from the court for years. The VA is slow in the pickup, but there is a big push from the court to discuss lay statements. And so the veterans have to have their lay statements at least discussed. So there are cases that specifically say that lay evidence is one type of evidence that must be considered, and the examiner's opinion is inadequate if they did not indicate whether they at least consider the veteran's assertions of symptomatology. So if they don't discuss it, they just completely ignore it, then it's not an adequate exam. Does that make sense? So back to the hypo. The examiner did not reference the 2012 statement, and so it should be considered an inadequate exam because they ignore the relevant lay statements. And this kind of goes off to what you were saying, that they didn't give any, opinion rationale that discussed it at all, so they need to look back at that. So here's some boilerplate. So read the examiner's opinion and determine whether there's relevant lay statements that should have been considered in the opinion. And if there are, then they should go back and they should say that it's an inadequate exam. Does that all make sense? Do you have any questions on these top 5? Yeah?
How do you argue if the VA examiner put in there that the lay statement was subjective? How do you argue?
So the VA examiner says, so he's asking, how do you argue if the VA examiner writes that it's subjective? Well, it is subjective in a way, right, because it's coming from a veteran. But that doesn't mean that it's not competent or credible. And so you can still argue that while it is subjective, they still need to address it, and that they need to talk about competency and credibility, and the VA does, not necessarily the examiner, and that show other evidence in the record that kind of backs up the veteran. Yeah?
Does that same apply to having to address medical treatment or signs of the evidence?
So yeah, so this actually, these first 5 are from a bigger presentation that we have the top 10 inadequate exams, and that I think is actually number 6. So if you have, and we are going to talk about this in a little bit different ways this afternoon too, but if you have a VA examiner that talks about, no, let me change that. If you go through and you've done a lot of these claims, right, and you know, hey, there's really good medical evidence or really good medical treaties, and you print it out and you put it in the claims file. If it's in the claims file, the VA needs to discuss it, and the VA examiner needs to discuss it. So if they ignore medical evidence or medical treaties that you've submitted, it's an inadequate exam. And you can call them out on that. So. Okay, before we continue with the lay evidence, do we have any other questions? Please feel free to ask questions. There are no dumb questions. My husband will probably tell you that I challenge that theory all the time, but if you're having a question, I'm guessing someone else in the room does. And I like to, especially if you think it's a basic question, ask it, because if you're going to keep thinking about it, you're not going to listen to me for the rest of the 45 minutes. So, yep. Sorry, can you tell me that there's like a talking back there? It's annoying.
How would you suggest addressing an examiner at certain facilities that employees attend from the exam?
Yes. So the question is, we all know there's these notorious examiners out there, right, that just keep giving the same bad opinions or stick to their guns on things. How do you address those? One, try to go after why it's inadequate, right? So don't go after the examiner personally, yet go after the exam why it's inadequate. Build up your record, get your private medical opinions if you can to try and combat it. If you have an examiner that is particularly awful over and over again, we are going to discuss later on where you can kind of go after this afternoon, where you can kind of go after like their competency a little bit. So that also might be something that you might want to bring up to your leadership. If you see someone over and over again who seems very anti-veteran or just giving things, that's something you should bring up to your leadership, that maybe that can be handled at a higher level. Okay, so lay evidence, the next part of this. We talked about it before, right, a second ago. One type of evidence that must be considered, not should be, but must be considered. So here's a hypo. The veteran served 1979 to 1980, 2003, 2004. So we're dealing with a reservist or a guard person. And their SCRs are negative for complaints, treatment, or diagnosis of sleep apnea. How often do we see these? Right? All the time. Side note. Who here took the TAP class when you were getting out of the military? Okay, I taught that in Japan like 9 years ago on a Navy base and on a Marine base. Iwakuni or Sasebo, if you guys remember those. And the Navy, they were all on top of the sleep apnea thing. So much to the point where the Navy base stopped doing sleep apnea exams for guys getting out of the military because they knew it was such a high rating. But sleep apnea is a big one that we see a lot. And you're not, when you are fighting, you're not going to worry about your snoring and go to medical, right? That's just not a concern. So these are ones where lay statements are going to come in a lot because there's not going to be anything in the SDR. So in a February 2010 VA treatment record, the veteran reported during service he fell asleep easily during the day. His wife said he snored loudly, and he was not sure if he stopped breathing while sleeping. So in July 2010, the veteran then filed a claim for sleep apnea, and in February 2012, the VA physician stated that, according to the veteran's history, he had witnessed a PNIC event, which is where pauses in his breathing, while deployed in Iraq, and he may or may not have had undiagnosed unobstructive sleep apnea at that time. Then he has a buddy statement that other soldiers observed the veteran having severe snoring problems while sleeping and waking up with shortness of breath. And fellow servicemen were concerned about the veteran because they constantly had to wake him due to his pauses in breathing. Snoring, pauses in breathing during sleep, and waking and shortness of breath are all symptoms of sleep apnea, right? So the buddy statements kind of go over that. In January 2013, he finally has a VA exam, and the VA examiner states that the veteran's sleep apnea is less likely than not had its onset during active duty due to the significant delay between discharge and subsequent diagnosis of sleep apnea. The examiner noted the buddy statement, so they note them at this time. So he notes the buddy statement about in-service snoring, but said that snoring in and of itself does not indicate sleep apnea. They say that the VA exam was a thorough exam, there was an adequate rationale, While the veteran reported the symptom of sleep apnea in service, the snoring, he was not competent to diagnose sleep apnea or give an opinion about the disease etiology. What do you guys think? Why?
It was more than just snoring, for one thing. It was way more pausing and all that.
All right, so she's saying that it wasn't just snoring. They also talked about the pausing in breath. They also talked about the shortness of breath and all of that. So, that's a great possible argument. They ignored evidence of shortness of breath in service. While lay people are not competent to diagnose sleep apnea, they are competent to report snoring, shortness of breath, and falling asleep during the day. You don't need to be a doctor to know these things, right? We all know what snoring is. You don't, even if you didn't go to med school. So a lay person is competent to talk about those symptoms. You don't need a medical degree for those. Another argument is the veteran snoring began in service, and it continued. He still had it after service. So he had some continuity going on there. So the RO must consider the lay statements that are relevant to the claim. The ROs often ignore or reject lay statements critical to a claim not documented in the official records. So usually, cooperation is not required if the veteran is competent to provide the evidence. So in this case, they just kind of missed all the buddy statements, right? And they missed the lay statements. But they were really helpful because a veteran is competent to talk about these symptoms. And a buddy statement is competent to observe snoring, something like that. So they have to look at all of those and discuss it. So usually for them to reject lay evidence, they define it to be not credible, and they have to explain why. They didn't do that here. So if you receive a rating decision in which the rater ignores or erroneously rejects the lay evidence, request a higher level review or go to the board, Rick's going to be talking a lot later about the AMA. But this is, if they go for it, you already have the positive evidence in the record. You probably don't need to do a supplemental claim. You can go after higher level review or go to the board on this one. So, lay evidence can be relevant to establishing an in-service incident, saying that something actually occurred, right? Establishing the continuity of symptoms. Talking about the current disability. An example for this is tinnitus. I know some of you might say tinnitus. That is wrong. It is tinnitus. It is tinnitus. There is no medical testing for tinnitus. They can't do any testing. So if a veteran says it, they got to kind of believe him on that one, right? Now, can a veteran say it's cancer? No, he's not going to be competent to diagnose that. But he is competent to talk about, tinnitus and kind of look at diseases like that, right? So, lay evidence is also helpful in triggering the duty to assist. So, we talked earlier about when you need to get an exam, those 4 elements. Lay evidence can be helpful in doing that, in getting an examiner opinion or in obtaining records. Lay evidence can also help the severity of the disability, talking about how severe the disability is. Okay, do we have any questions? Really? I'm not that good. No questions? Okay. Now, Rick alluded to this earlier. I think someone had a question. So if I don't answer that earlier question, please bring it up again. So the effects of medication. So we see this a lot, right, in headache cases. So those veterans trying to get a rating higher than 10% for headaches. So let's look at the rating criteria. So the 50%, from the 0 to the 50, it's all talking about the attacks, right? How frequently they occur and how bad they are. That's kind of the rating criteria for the attacks, for headache. So here's a hypo. The veteran takes daily medication to manage the severity and frequency of his headache. He still had a prostrating headache about every other month. The VA found that an increased rating was not warranted based on the frequency, severity, and duration of symptoms. The VA found that the veteran was able to properly manage the symptoms with the use of medication and did not require any significant time off from work due to his disability. What do you guys think?
If you have a prostrating headache once a month, I would suspect that you're probably not working or being very effective at work during that period.
Okay, well, you need for 30% rating, you need a prostrating headache once a month over the last several months, and I think he had it once a month, every other month. Yeah. So, what else?
I think he'd have to know himself, how many times is he going to have a headache if he's not taking his medication. He needs to be able to tell that to the VA examiner. If I don't take my medication, I get these every day.
Okay.
With my medication, every other month.
Okay, so he's saying that he needs to be able to tell the examiner how his medication stops him from getting more headaches. If he wasn't on the medication, then he would have more headaches. Now, do we think that the VA should be considering the medication or not considering the medication in giving when they're looking at the higher rating? What do you think?
Not.
So, do we think they should be considering the meds and how much are on it? Do we think they should not? Okay, this whole little center over there, not participating. I'm looking at you. Not participating. So we're going to do it again. Okay, so who thinks that they should be not considering the medication? Who thinks they should be considering the medication? Okay, so let's see. The veteran cannot deny entitlement to a high rating on the basis of relief provided by medication when those effects are not specifically contemplated in the rating criteria. So it all depends if the disability rating criteria talks about medication or not. So if there's no mention about medication, which there isn't in the headache one, right? That just talks about prostrating attacks, not talking about medication. Then the VA is required to discount the positive effects of the medication when assigning the rating. However, let's flip that. You do have disabilities like mental health, right, hypertension, which do have medication in it. Then they can contemplate the positive effects of meds. They don't need to discount the medication when rating it. So you have to look at the rating criteria and see if it specifically talks about the medication or not. If it does not specifically mention the medication, then the VA is required to discount the positive effects of the meds. If the rating criteria specifically talks about medication, then they do not need to discount the positive effects of the medication. Does that make sense? So kind of get yourself, look over it and see. So in the headache one, they can't talk about it. So this is where lay statements are great in talking about, how bad, or getting statements from doctors, or stuff like that, and getting that into the record. Can you talk a little bit louder? I'm sorry.
Another form of medication when you look at the chronic is also the medication's effect on the body after effects, such as prednisone or Jordan and stuff like that, you call it clean. So when you look at medications, how it affects after effects on the body also.
Yeah, so he was saying, you can hear, that just so you guys, there's like some auction going on over there. In the back, you can hear it, but I was listening to an auctioneer the entire time. So that's why I bet it to be louder. I guess some hemp auction is going on. I don't know what's going on over there. But, so, he brings up a really great point. And we're not talking about secondary service connection today, but this is a great point. If you are on, or you have a veteran who's on a medication for service-connected disability, and that then causes another disability. So he was talking about prednisone. I've been on prednisone. I had the big fat chipmunk cheeks, gained weight. It can destroy your body if you're on it for a long time. If you are on that and you get another disability, you can get that service connected as well under secondary service connection. So if you're talking to a veteran and you see they're on medication for a service-connected disability, if you're looking at a rating claim, you pull it up, see if it's part of the rating criteria, then also ask them, well, do you have anything else? And it can be, you can get secondary service connection for that.
Even on the primary, too.
You-
Even on the primary, if you were long service on one dosage protocol, you're on the primary.
Right, yeah, but if you were, he's saying you can also get the primary disability, if you're on prednisone during service, you know, that can kind of then create a disability. That would be your in-service event, injury, be the in-service prednisone. So, but yeah, that's a great thing to keep that in mind. Yep.
Can a VA deny a veteran disability if he refuses to take medication to know some side effects?
So they can't deny service connection, right, for that. If you have a disability, you have a disability, how you want to treat
What's
it.
the degree of it?
But when rating it, no, they would just then base it on the current disability. You can't make a veteran go on meds, right? So what I keep thinking of during this question is mental health. You might have veterans who have bad mental health, and because part of that might be non-compliance with their medication. You can't force them to go on medication, right? For mental health rating criteria, it's in the 10%, but it's not considered part either. So they can't use that against them. Like they can't use not going to treatment, not going to group, or anything like that against the veteran. So, do we have any questions? I love when people ask me questions. No, I haven't put you all to sleep yet, so. Since we said review the diagnostic code at issue for any reference to the medication. If a diagnostic code does not specifically mention anything about the meds, the VA is required to discount the favorable effects of the meds. So make sure you look at it. Have them write their statements. Have them get it all, you know, you have to go back to their doctor. Or show like, hey, before they were on their meds, look how it was. Now another thing, and you have to look at the rating criteria, and I can't for the life of me all of a sudden remember the exact rating criteria, if it has meds in it or not, but I don't think it does, is I've done it with injections, right? Steroid injections or spinal injections to make the back better or to make a joint better. It's not just oral medication, but it can be injections. So look at that too. Look to see, you know, if they say, you know, I have such a bad issue, back problem, but I'm on these injections, so I'm doing a lot better. Now, a lot of times, you'll see in the record that they're doing injections, and the injections are doing diddly squat, right? That's not going to help them get the higher rating, but look to see too. Don't just go for your conventional pills to see if there's other medication types out there. Yes?
This may be completely off topic, but
That's okay, we have time.
I want to talk about pain management, because I have veterans that require pain medication, but now they're making them jump through hoops. You have to go to the pain management clinic, and in order to continue going to the pain management clinic, you either have to do physical therapy or take those injections, or you don't do medication.
Right, so Okay, so what's your question?
My question is, why can they do that? I mean, how can they say, in order for me to get the medication that helps me not be in pain, I have to undergo this other medical treatment?
Oh, okay. So her question has to do with, if you can hear it, is why do they make some veterans jump through hoops to get their medication in form of pain management? So instead of just giving them the medication, they might get them to go to physical therapy first and stuff like that. And how can they do that? I'm not a doctor, and doesn't usually come up in the VA world, but from my own opinion, I would think if there's other ways to help a veteran without putting them on a lot of drugs. If you all see the news now, there's a big opiate issue, and they're probably trying to find ways to not increase the opiate problem.
If somebody's had degenerative joint disease in the knees for 25 years, and taking a Tylenol-3 will help them if they have to take it like twice a week.
Well, I don't think, so she's saying they've degenerative joint disease in the knees for 25 years, and they have to take a Tylenol-3 twice a week. I don't think that's usually what they're jumping them through for the pain hoops. I think it's more for their opiate issues. But I think it's also, even being on Tylenol a lot creates liver issues and kidney issues, and they're probably trying to find other ways to not make people dependent on medication.
I mean, it's because, those shots, those steroid shots don't always work. Physical therapy is not going to help with that.
But I think they try to do other things so people are not on their medication. Okay, so argue that the VA needs to rate the condition based on how bad it would be, and obtain a medical opinion if necessary. 36 points to evidence in the record showing the severity of it, and submit lay statements about the symptoms. Okay, so now I think this is our last topic. Common VA errors in mental disorder claims. There's probably a lot, right? So I always, when I explain the rating schedule to people, I kind of say it's like a plug and play, right? You look at the symptoms, you see if the veteran has it. If they have it, if they don't have it, that's the disability rating they get. However, the mental health rating criteria, probably contrary to what some of the VA people think, it's not an exhaustive list. You can have other symptoms and still get a disability rating of that. You don't need to you don't need to meet either every single criteria. You can have additional symptoms. So one of the things when they do it, when you look at it, is if you see a veteran who has other symptoms that are not listed in the rating criteria, talk about them. Say if they're similar severity, frequency, duration, and talk about how that makes them be able to get to 50 to 70 or whatever. So don't just worry about the symptoms that are listed. Look at everything in the record and see what argument you can make for them. The VA, they don't do that, right? They kind of treat it as a checklist. They also don't go outside the rating criteria, so this is kind of where you guys drawing your block, showing them the math homework will be really helpful to them. Sometimes they add on. And so what we're going to specifically talk about now is suicidal ideation. And sometimes they add on to that, right? So sometimes they might say passive or active or change it. So this is what I just talked about, that not an exhaustive checklist. You can talk about the similar severity, frequency, and duration, and the analysis should just not be limited to what the symptoms listed in the rating criteria are. So this is the rating criteria for the 70%. So as you can see, right, the first part is the rating criteria, occupational and social impairment, deficiencies in most areas, such as work, school, family, relations, judgment, thinking, or mood. And then it lists a bunch of symptoms, right? And it just says symptoms such as, so it means you can talk about other ones. Now this, it just says, what's the bolded words? Just suicidal ideation. Now, suicidal ideation is not listed anywhere else in the mental health rating criteria at all. While you have some, like Like depression, right? Depression kind of works its way up. There's different levels of it throughout the rating criteria. So you get, 70 has continuous, near continuous panic or depression. There's other levels. Suicidal ideation is only listed in the 70% criteria. So here's an example. In denying a 70% rating for PTSD, the VA noted that the veteran did not suffer from a severe level of suicidality or suicide ideation. Is this adequate reason to deny a 70% rating?
No.
You guys sure?
Yeah.
Okay. Correct. That is not part of it. The only thing it says is suicidal ideation, right? There's no other words around that. Suicidal ideation can be continuum. It can be a lot. It can be going from active, where you're actually coming up with a plan, you're working on it, you have a plan, you're ready to do it, versus passive, where I just occasionally think about it. That is all suicidal ideation. Does not matter where you are on that spectrum. In denying the 70% rating, the VA found that the veteran has not had difficulty with the law, has not been shown to be violent, has not made suicide attempts, and has not been shown to have a problem with alcohol and drugs. Is this an adequate reason to deny 70%?
No.
You're sure?
Yes.
Correct. There is nothing that talks about intent or attempt for suicide. Just suicidal ideation. The other reasons, what else did they say? They say difficulty with the law, has not made suicide attempts, has not been shown to have a problem with alcohol or drugs. Where are they coming up with this? This is not part of the rating criteria. Now, if he does have these things and it helps you, then you can argue similar severity, frequency, and duration. But if he doesn't have them, they can't use it against him, right? Did I see a hand? No. So the rating schedule does not distinguish between passive and active suicidal ideation. It just does not discuss the level of suicidality. Also, hospitalization is not the standard. So it does not matter if a veteran has ever been hospitalized for their suicidal ideation or not. They cannot use that against the veteran if he was not hospitalized. Also, it doesn't need to be continuous. He doesn't need to go to every single doctor's appointment, every single exam, and say he has suicidal ideation. It can be fleeting. That's okay. It doesn't need to happen every single day. He doesn't have to do it at every exam, and there does not need to be a plan or intent to act on it. So, symptoms must cause occupational and social impairment in most areas. Sometimes it alone may cause that level of social and occupational impairment, since there's no comparable symptoms listed in the criteria for the rating schedule, right? But not necessarily, if you just have that, will that always give you a 70% rating, but you can argue that it gets you there. If the VA cites any of the above reasons, so if they say he wasn't hospitalized, it wasn't at every exam, it's not continuous, it's not fleeting, it's just passive, it does not matter. Suicidal ideation is suicidal ideation. Okay? There's no distinction. Now, keep this in mind if you see them doing this with other, other symptoms. If they do this, argue this cascade and how it does not matter if they can't read more into the rating criteria than what is listed. Do you guys have any questions? We have time, so. Okay, so I guess we are good for lunch. Hold on.
All right, let's give her a hand.